Hi everybody and welcome to our Michigan Medicine live event. I'm Ed Bottomley with the Michigan Medicine Department of Communication, and today we'll be discussing stroke. We'll be diving into this topic with our panel of experts to get to the facts. So first things first, let's go down the line and meet our panelists today. Start with you, Dr. Sozener.
Hi, I'm Cemal Sozener. I'm an emergency physician and I'm the emergency medical director of the Comprehensive Stroke Center.
I'm Mollie McDermott. I'm a stroke neurologist and the medical director of the Comprehensive Stroke Center.
I'm Ted Claflin, and I'm a rehabilitation physician and the director of the Stroke Rehabilitation Program.
Thank you all for being here. Just a reminder to our viewers, you can submit questions at any time, even now, for our panelists to answer. Questions can be submitted by commenting on this video, but please note that your name or your profile name will be visible to others participating. If you want a more anonymous option, you can also private message us via Facebook. And if you can't stay for the whole chat or want to share a recording of this chat with a friend, a video of the chat in its entirety will be up on the Facebook page and also posted to our Michigan Medicine YouTube channel shortly after that. So let's move on to our questions. The first question is, what is a stroke?
So a stroke, Ed, is essentially it's a sudden loss of blood supply to a part of the brain. It's typically a clot or something that lodges in one of the blood vessels of the brain, and it causes a sudden loss of function of a part of the body. And the hallmark symptoms are going to be loss of function on one side or the other. So typically arm or leg, or sometimes both, weakness on one side, difficulty with speech, difficulty with vision, difficulty with balance. And again, the hallmark feature is that it's a sudden onset.
Okay, and our next question, spinning off that, does it affect a lot of people?
Yes, stroke is very common. In the United States, 800,000 people have a stroke every year. Stroke is something that likely has affected a family member, a friend, or even some of the people that are with us today. So everybody knows someone who's had a stroke. It's a very, very common disease.
Next question I have, are there different types of strokes?
Yeah, I can take that. So there
Sure.
are really two different types of stroke. One is the type of stroke called ischemic stroke, which is where a part of the brain does not get enough blood flow. And so that's caused by a blood vessel narrowing or a clot blocking that blood vessel and not allowing enough blood to get past that to feed the brain tissue, which can lead to problems. The other type of stroke, which is not as common, it's about 1/5 of all strokes, is a hemorrhagic stroke. And that's when a blood vessel breaks and there's bleeding into the brain or around the brain.
The next question we have, do strokes hurt?
That's a good question. So it depends, as Mollie was mentioning. So strokes that are hemorrhagic, or the minority of strokes where there's bleeding into the brain, those will typically cause pain, and that usually is described as a sudden onset severe pain in the head or a headache. Ischemic strokes typically do not hurt. They in general will present with symptoms like the loss of function, but won't cause pain.
Interesting.
And I would say stroke doctors kind of complain about that because we feel like if strokes cause pain, people would get to the emergency room more quickly, but because they don't, people are tempted to say, oh, let's just kind of wait a little bit and see if the symptoms go away, and then sometimes we lose our opportunity to treat people. So unlike heart attacks where people are uncomfortable and say, I want to get to the emergency room, this is scary, strokes sometimes, because they don't cause pain, can lead to delayed presentations.
Thank you, that's an important point. And spinning off that, what effects can a stroke have on the body, on the brain?
Sure, I'd be happy to take that one. So I think that the short answer, which seems sort of like doctors, is it depends, and it depends on how big the stroke is and where it affects the brain. So people can have problems that affect essentially any of the brain's functions, including vision, including motor weakness, sensory loss, coordination, swallowing. So essentially any problem that people can have, and just to add on to what Mollie was saying, it's critically important that people get to an evaluation, typically an emergency room, if they feel that they're having a stroke, because the interventions available are going to be most effective typically in the first few hours.
Thank you for that. Next question, who is at risk? when we're talking about stroke?
So everyone's at risk. So in general, one of the popular misconceptions is that stroke is only for patients that are elderly, and that's not true. Anybody, even babies or children, can have strokes as well. It's far less common, and in general, when you look at all patients that have stroke, the majority will be over the age of 65. However, there are plenty of patients that have strokes younger in life, and this year we've had, unfortunately, several celebrities that have had strokes that have been younger as well. So that's, through a bad mechanism, drawn some attention to stroke, which is always good because, as Mollie had mentioned, we want to get those patients to the hospital immediately when they have those symptoms.
Thank you for that. And then, so my next question, we've dealt with age. Why do strokes happen to healthy or otherwise fit people?
Yeah, that's a good question. And you could ask that of a lot of different diseases, right? Why do these happen to people without a number of risk factors? There are conditions that can predispose one to stroke that you may not know about. So sometimes people have high blood pressure and don't know about it, or have heart problems and don't know about it. These are things that we find, conditions that we find generally in our workup for stroke. But a certain percentage of the time we say, we don't really know why this happened. Despite our workup, despite all of the tests and studies that we've done, we didn't really find a clear reason why this happened. And that's just an unfortunate truth of stroke workup. Sometimes we don't know.
Thank you for that. Now, how do you know if someone's having one?
That's a good question, and that's a really important question. So, as Dr. Sozener said, the key is that strokes start like this. They start quickly. So things that kind of that creep up on you all day, probably not a stroke. But sudden onset weakness, numbness, trouble talking, trouble seeing, dizziness, trouble walking, trouble swallowing, new neurologic symptoms that start suddenly, and especially when they involve one half of the body, are very, very concerning for stroke.
And is there an acronym, FAST?
There
Have I got that right? Can you tell me about that?
You've got it exactly right. So FAST has been an acronym that we have really tried to get out there into the community, and you've probably seen billboards with it on. You've had it on the side of buses here in Ann Arbor. But so F is face. So essentially face droopiness. Again, all these hallmark signs would be sudden onset, as Dr. McDermott had mentioned. So F is face, A is arm, so weakness of the arm. S is speech, so obviously if there's any changes in speech. And T we use as time, which kind of pushes forward how important it is to get treated quickly in stroke. We have some options for patients, but it's really all time dependent. So we want people to call 911, use time to their advantage, get to the hospital as quickly as possible once these symptoms start.
And that conveniently moves on to one of our spin-off questions. What do you do if you realize someone is having a stroke? Call 911 versus drive to the hospital.
Again, I think it's a fantastic question, and I would say 100% of the time call 911. I think that's, as a friend or family member, or if it's yourself, the one most important piece that you can do is call 911 and get to the hospital quickly. And the reason for that is because the 911 or the EMS system really primes the hospital and gets the hospital prepared for that patient to come in, so we can do things very, very quickly when that patient arrives. It's surprising, even in wonderful communities like Ann Arbor, when you look at the percentage of patients that utilize EMS when they're having a stroke, it's still lower than what you would expect. We're just over 50%, which is far lower than we'd like to see. We would love to see 100%. That's not possible, I know, but getting up into the 80s and 90s would be fantastic, because those patients have been proven through research across the country and the world that they'll get treated more effectively and faster if they use EMS and come in by ambulance as opposed to private vehicle.
I just want to add on to that. Some people say, oh, it's just numbness or just a little bit of weakness. I don't want to use these resources. I don't want to, sound a false alarm. But no one will ever think that it's overkill or that you've done something wrong if you call 911 because you think you're having a stroke. And in fact, we'll praise you in the emergency room for calling 911, because it's very, very important to do that.
The next spin-off question we have: how are stroke symptoms and causes different in younger people?
So in terms of causes, so let me say stroke symptoms, the same. Your stroke symptoms depend on where in your brain there's a problem with blood flow, and so you can have the same symptoms when you're young as you do when you're old. in terms of causes, there are certain genetic conditions that are more likely more likely to cause stroke in younger people, or we see it more frequently in younger people than in older people. And also, drugs of abuse are a very common cause of stroke in young people. So, maintaining a drug-free lifestyle is important for preventing stroke.
Sure. The next question is about mini stroke. What is a mini stroke, and is it the same thing as a TIA?
So a mini stroke in general. So a TIA is a transient ischemic attack. It's a fancy term. Essentially, it's the same thing as a stroke. The only difference is the symptoms resolve within a short period of time. And so many people will refer to TIAs as a mini stroke. So anytime we have symptoms that look like a stroke and then they go away without treatment, we would call that a TIA or mini stroke.
Okay.
But the symptoms are the same.
Sure. What early treatments are available for stroke?
So we're very fortunate. We have lots of treatments. Essentially, we can kind of put them into two groups. Number one is the most commonly used treatment, which is an IV clot-busting medicine. It's called TPA. It's been around since the mid-90s, and we've been using it a lot across the country. It's an effective medication that if we can give it to you quickly enough, it can go through your system and ideally break up the blood clot that might be causing your stroke in your brain. The important thing to think about with TPA is that we can only give it to a patient in a very, very narrow time window, and that's all dependent on when their stroke symptoms started to when we get the medication. And in general, the maximum time currently that we have is about 4.5 hours since the onset of symptoms. And again, that really pushes forward why it's so important to use EMS or ambulances to get to the hospital quickly and to come into the hospital quickly as soon as you have those symptoms. We also have newer therapies where we can go in, similar to heart attacks, where we go in through the groin in a blood vessel and then put a catheter that goes up into the brain to try to take out a clot. And we can use that a little further out, 6 hours and sometimes even out to 24 hours, but that's for really large blood clots in more of the central blood vessels of the brain. So that is only a therapy that we can give to about maybe 10% of patients because they're having a massive stroke. But the vast majority would be getting the IV clot-busting medication.
Next question. We've touched on this a couple of times, but I think it's definitely worth reiterating. Why is it important to get to the emergency room quickly if you're having a stroke?
Yeah, so the trial after trial in our field has shown that the sooner you can be treated, the better you do. And it's as simple as that. And so getting to the emergency room quickly, getting treated quickly, unequivocally improves outcomes. And so the faster you get treated, the better, so get to the emergency room as quickly as possible.
Thank you. The next question, is there anything you can do to prevent a stroke?
Yeah, so yes. There are certain conditions that, as I've kind of alluded to before, can predispose people to stroke. So high blood pressure is associated with stroke. Smoking is associated with stroke. Heart conditions like atrial fibrillation is associated with stroke. And so making sure that your blood pressure is controlled, that if you are currently smoking, you cut down dramatically, or if you're able to quit, ideally. If you have a irregular heart rhythm like atrial fibrillation, being on a blood thinner to prevent blood clots from forming and causing stroke. And then sort of general recommendations for heart health and brain health in general, keeping a healthy weight, trying to eat fruits and vegetables, trying to limit sodas, sugars, carbohydrates, things of that nature, and getting exercise. At least 30 to 45 minutes a few times a week of low impact exercise is a great way to not only prevent stroke, but to keep your weight down and keep your blood pressure down.
Great. Dr. McDermott, you may have touched on this a little bit, but we have a viewer question. Are there aspects of nutrition we should pay attention to?
Yeah, that's a good question. And as you can imagine, studying nutrition is difficult. You try to imagine putting people on different nutrition regimens and seeing how they do over time. Well, we're humans. It's hard for us to adhere to different nutrition regimens. And so our data about nutrition and risk of disease is largely just across populations. How does this population do? How does this population do, given their different diets? Our best evidence in 2019 with these limitations of that this is a hard thing to study, suggests that the Mediterranean diet is the best diet for reducing heart disease and stroke. And so you can actually Google what does the Mediterranean diet consist of, and you can find a list online of the different foods. It's generally, you'll read the list and say, yeah, that makes sense. I know I'm supposed to be eating that stuff, with the addition of some nuts and olive oils and things of that nature, which you may not instinctively know.
Great. Let's move on to our next series of questions. We're going to be talking about after a stroke. What's the recovery like?
Generally, the recovery, I think based on the literature, most of the neurological recovery, restoration of the functions that have been lost, is going to occur in that first 3 to 6 months. Thereafter, there's certainly opportunity for additional improvement, but I think most people are going to notice that those incremental improvements are harder and harder to come by, require increasing amounts of work, and the payoff in terms of recovery tends to level off.
Okay. And the next viewer question we have, what is the best way to keep your spirits up as well as manage anxiety and stress?
This is a great question. I think depression and anxiety after a stroke are terribly common and often complicate people's recovery. I don't know that there's one best way that people can manage that, although certainly I think, my first recommendation would be, if that's a problem, people really need to be sure to that they're talking with their providers about it, so that they can have an opportunity to hear about all of the available interventions. I think most sort of classically in medicine, we talk about psychotherapy and counseling, so helping people with adjustment to disability. There are specific rehabilitation psychologists that we can make available who are trained specifically for that purpose. There's also certainly plenty of medication options available. And then more generally, I think that family support, social support, and optimizing sleep and exercise are probably the next on the list of things that we would be recommending.
Thank you for that. What's the likelihood that someone can get back all of their mental and physical abilities?
I'd be certainly happy to have Cemal or Mollie jump in if they don't agree with this, but I'd say it depends. Unfortunately, the likelihood of getting back normal functioning decreases as the size of the stroke in particular increases. So the bigger your stroke, the more brain tissue's been affected, and unfortunately we're still not able to regrow brain tissue or get that to change again. So if there's a chunk of brain tissue that's been lost, that's incredibly difficult for the brain to overcome. If there's a much smaller lesion, then it's much more easy for the brain to have some adaptive mechanisms where they can have good improvement. So for a very small stroke, the odds are fairly good, and for a very large stroke, the odds are significantly lower.
Even when people have had a small stroke, they'll sometimes find that if they get sick, stressed, overtired, some of their stroke symptoms can reemerge, and this is something called recrudescence. It's sort of a funny word, but we see it a lot, and so it's scary because people will say, well, these are the same symptoms I had when I had my stroke, but it's not a new stroke. It's actually that the rest of your brain, which has been compensating for the stroke, all of a sudden has to pay attention to something else, whether it's the flu or you didn't get any sleep last night, and so those symptoms can kind of reemerge a little bit, and that's a good thing for people to know about so that it doesn't freak them out too much.
Okay, and moving on to our next question, what is neuroplasticity?
Neuroplasticity is the idea that parts of your brain that have not been hurt by a stroke or other injury can kind of be play a volunteer role and serve the function of an area of the brain that was hurt. So let's say you have an area of the brain that's been affected by stroke, maybe some brain areas adjacent to that can kind of kick in and take over the functions that injured area of brain was previously serving. And we know that happens because we know, based on imaging, that people have irreversible brain injury on their in their brains, but they don't have any symptoms. And so we know that's possible.
Thank you for that. Is there a window of time after which further recovery is not possible?
I don't know about possible. I think, like I was saying when we were talking about the time frame of recovery, I think that probably after that first year, people are going to find that incremental improvements are increasingly hard to come by. But just like, if I decided I wanted to improve at juggling or something, all of those normal mechanisms for improving a specific function are still available, and people can still make improvements, but they're much more difficult to come by, and they're less long-lasting. People will find that they can make shorter-term improvements with some individual exercise or therapy, but that's going to fade more quickly. This is part of the reason why the emphasis in general is on trying to engage in the most intensive therapy program possible in the early months after a stroke, because we feel that often the improvements made in that period of time are going to persist. And so those, if you can get back as much as possible during that chunk of time, that should stick.
Thank you for that.
I've noticed, and maybe, please correct me if you disagree, but I've noticed that whereas maybe the motor function can continue to improve 6 months after stroke, language seems to improve for longer. You have a longer window to improve language, and it's largely dependent on, if you use it, you don't lose it. So I have seen people continue to improve in their speaking, their language abilities. So in this case, I'm talking about finding the right words, using the right words, understanding language, not slurred speech. That's a different entity, but language itself can improve out to even a year from stroke.
Mm-hmm. Certainly, language difficulty or sometimes cognitive problems can both, we often see recovery last longer. But again, I don't know about you guys, I think I would probably say a year or two is probably on the long end in terms of when people are going to notice improvements that are happening after that stroke that seem to persist after they've improved and not be quite so hard to work at and then fade again afterwards.
Next question is about rehab. How important is rehab to stroke recovery?
I think we think it's fairly important. I think a lot of the studies that have been done show that the intensity of therapy and intervention immediately after a stroke do correlate pretty well with how well people recover. I think a lot of that is felt to be because more intensive therapy is going to trigger, we hope, more optimal neuroplastic changes in terms of those neurological central nervous system mechanisms of improvement. The more you use it, the more your brain's going to work at trying to make that impaired function better. So, just as us going for a short walk isn't going to improve our cardiac endurance, you have to really work at it to try to trigger those areas of the brain, get some excitability or excitation of those neuronal systems in order to facilitate further improvement. So in general, we'll be evaluating patients for essentially the most intensive therapy program that they're going to be a candidate for or can tolerate, and trying to get them engaged in that type of program.
Fantastic. What is the process like, and what kind of specialist should someone work with to get the best results?
What was the first part of that? What's the process?
Yeah, sorry.
Process? I'm just
Pronunciation.
So the process in the hospital is typically that we'll have therapists evaluate the patients and get a better sense for what are that person's limitations and what are their capabilities. And then depending on their evaluation, they might engage some of the other therapists or maybe a physician like me who's a specialist in rehabilitation. So from there, we would be trying to triage again what type of program is going to be most appropriate for any given patient, with the default really being if somebody can tolerate a more intensive therapy program, we want to get people into those types of programs because outcomes are better in terms of function as well as managing and addressing complications. What types of providers do need to be engaged is going to depend on the problems that somebody's having after a stroke. So essentially for all of the different types of problems that can happen after a stroke, there are specific types of providers that would be best to intervene. So if you're having a speech problem, we have speech pathologists. If you're having motor problems and weakness, then that's something where we'd be engaging physical therapists, occupational therapists. I think I could enumerate a number of other examples, but there are all kinds of different providers. And that's sometimes where, say, your neurologist or the rehab physician would be able to direct you what's the most appropriate people to engage.
Next question we have up, what is a comprehensive stroke program? How does the care differ there, and how does it benefit the patient?
So here at the University of Michigan, this is a comprehensive stroke program, and essentially in the United States, a lot of the accrediting bodies will kind of provide different accreditation levels in terms of the amount of resources or the different programs that you have available to be able to help your patients when they're having a stroke. The comprehensive status is essentially the highest status that you can achieve in the United States, and it's a hospital that is able to take care of any aspect of stroke, including hemorrhagic, as we mentioned, or bleeding in the brain versus ischemic, and it has all of the provisions available to be able to do endovascular therapy, which is the catheter in the groin going up into the brain to pull that out on a 24/7, 365 basis, and extends all the way through stroke rehabilitation. So we're very fortunate in this community. This is, we have a center that can provide every aspect of stroke care that you need.
Great, thank you for that. How about inpatient and outpatient rehab? How do these programs work together to optimize the outcome?
So inpatient rehabilitation is, like I said, that first more intensive step. Subacute rehabilitation is often in between. That's typically for people who either aren't candidates for the more intensive for whatever reason. And either one of the more intensive or less intensive inpatient programs really needs to facilitate that transition to somebody getting back to the community. That could be that they're getting back to their own home, that could be something else. But that transition point means that we need to be preparing that person for that transition back to a community setting, essentially from the day of their stroke. And this is, from the rehabilitation provider's perspective, this is exactly what our job is not necessarily just to be focused on the short-term rehab, but preparing that person to make that transition back home safely. When it's done optimally, I think that, for example, here, if somebody were to come to our emergency room, they get to realize the benefit of coming to a comprehensive stroke center and having somebody like Dr. Sozener available, then get admitted to the neurology unit where they're making best use of Dr. McDermott's expertise, come to the inpatient stroke rehabilitation unit, and then have us transition to our outpatient stroke rehabilitation program. Staying in one system, all of that information is available to all those providers, and then we're preparing that outpatient program for this person and their specific needs. That's much more difficult if somebody's, say, coming to our inpatient neurology unit and then going to a different inpatient rehab program and then going to a different outpatient rehabilitation program. Certainly, there's not a insurmountable lot of information there. People still can learn about what's happened to somebody, but I think that when we do it right, we are viewing somebody comprehensively and transitioning all that information to their next level of care.
Thank you for that. We have a viewer question about rehab. After a stroke, if one side seems to be stronger or one side is paralyzed, is it compensating for the other side? Does that affect overall mobility over time in the years after a stroke?
Yes, I think it would be the answer to that first part about, is the stronger side of the body compensating? Yes, of course, to some degree. We're going to be asking people to try to get moving again, and they've got stronger muscles in one place. It's very natural for that person to use those muscles to do the things that they're trying to do. I think that's also part of what we're trying to work on over time. So the degree to which somebody gets motor recovery on their weak side, we want to capitalize on that. We're going to be working very hard to move that side as much as possible and get it to do as much of the work as possible. Could you remind me what the last couple points are?
So if one side seems to be stronger than the other, or one side is paralyzed, is it compensating for the other? So that was the first half. The second part, does that affect overall mobility over time in the years after a stroke?
I don't know that the stronger side compensating necessarily affects people's long-term recovery, as long as they get good rehabilitative services that are trying to work on restoration of the function of the weak side. I think if somebody, for example, as sometimes happens, says, I appreciate you offering me these rehab programs. No, thank you, I'm going home. We will see them later on and find that those people, just by lack of using the impaired side at all, suffer the consequences of not using it, whether that be atrophy or contractures and loss of range of motion. They just can't move it or use it very well. So that's, I think, the greater issue. The side that's working fine should work fine separate from that as long as they keep using it.
Thank you.
Any other input, guys?
No, yeah.
Okay.
Next question we have, what are the different types of therapy available?
Why don't you've been talking a lot, so I'll chime in and then you can fill in the blanks. So as Dr. Claflin mentioned, for trouble with talking and trouble with swallowing, there's speech-language pathology. For trouble with walking, balance, sort of larger movements of the body, there's physical therapy. For trouble with some of the tasks that we need to do to take care of ourselves, like dialing a phone or picking out clothes or cooking, there's bathing, there's occupational therapy. There's also cognitive and psychosocial therapy for people who have issues with depression or anxiety after stroke. There is social therapy, so support groups where people can join with other people who have had a stroke to talk about some of the issues. And then I would add sleep therapy. So for people who have trouble with sleep, there are both counselors and devices and medicines that can help with sleep after stroke.
I think that's perfect. I think therapy can be a term for pretty much any treatment intervention trying to help somebody. So the types of therapies that we use after a stroke most commonly are perfectly well delineated, but of course there's a myriad of other things available to people for different types of problems.
Makes sense, thank you. Is there a point where patients will no longer improve with continued rehab care?
I think that's a really great question, and of course for anybody recovering from a stroke or who has a loved one or family member or friend, this is the crux of, when do you stop pushing as hard? It's a lot easier right after a stroke for somebody to stay motivated, for you to feel that the investment in transportation and time is well spent. And I think that what we've been trying to detail is that for everybody in their recovery journey, there will be incrementally smaller improvements over time. Of course, that point of this is no longer worth the time, or I'm not seeing further improvements, is really probably going to be different for everybody. I certainly have patients that I follow on a long-term basis who are continuing to hammer away and continuing to realize those small improvements. And for them, that investment is worth it because they want to see that they're maintaining their gains. They want to continue to improve. And for other people, that same therapy program would be madness, would just be an insane expenditure. Something that they couldn't afford without bankrupting themselves. And so for those people, they're going to have to find a different balance point. I know that that's a little bit of an unsatisfying, hand-wavy, vague answer, but we're doctors after all, so that's okay.
Well, you know what? I think this moves nicely to our next question. How is rehab tailored to each patient in terms of different goals, interests, abilities?
Sure. I think that we do, it's often our sort of default mode that we're going to deal with your medical issues first. And so I think we do a very good job of trying to assess those. For example, Dr. Sozener, Dr. McDermott are going to be focused on what are this person's neurological impairments, where is that stroke, what do we think caused it, those kind of things. Longer term, I have more time with people on the rehab unit. They might be with me for a couple of weeks. And so we get time to dig into what are this person's difficulties, but also where are their strengths and what makes them excited about moving on with their life. How do I engage that person to keep them motivated? Are we going to get that person back to adapted cycling? Are we going to get this person doing the things that they still really enjoy? So I think that is much more of a detailed process. This is part of what happens often in a rehab program, is that the therapists are going to be spending a lot of time with people, the docs are going to be spending a fair amount of time with people, and we can start to probe those things, figure out what they're still having trouble with and how to address those problems, and also figure out where are their strengths, where are their passions, and how do we engage those.
Fantastic. How does stroke rehab differ from cardiac rehab?
Cardiac rehab is a type of rehabilitation that somebody would get prescribed after they had, for example, a bypass or after a heart attack. And that's primarily focused on getting the heart working as well as it possibly can. Typically, that's going to be an aerobic exercise program. And so they're going to be monitored to make sure that their cardiac health is stable while just basically getting put on some type of device to make them sweat. and so it's less focused on specific neurological impairments. For example, stroke rehabilitation, we are certainly wanting to do that same type of aerobic training. There's absolutely benefit to that, and hopefully in the future we'll be able to get insurance, for example, to pay for more therapy. But we're really trying to use, when we talk about stroke rehabilitation, we're really talking about a comprehensive program that's going to address all of that person's neurological and functional impairments in a detailed, person-centered way. And that's going to be separate from just having them hammer it out on a treadmill or something.
Sure. Our next viewer question, what about acupuncture or massage?
What about it? I don't think that they have a very clear role in stroke rehabilitation, at least as far as I'm aware. They are both things that certainly clearly have benefits for various problems that people can have, but specifically in terms of optimizing somebody's function or neurological status after a stroke, I don't know that there's a clear role for them in any of our programs. I certainly think that there's ongoing research to figure out how we best use those interventions.
Sure.
Yeah, one of the biggest problems with those interventions is that insurance really won't cover it. And so it's an out-of-pocket expense without a ton of data supporting their use. Now, if you've tried it, you can afford it, and it works for you, you should do it, absolutely. That no question if it's helping, but it's not something that we can prescribe, not something that we can get insurance to pay for, unfortunately.
Yeah, I might say beyond that a lot of people will come to me with a specific thing that they'd like to do, asking if they think it's appropriate. I think the general sort of best guidance we can give is that in the absence of great literature to support it, do check with your doctor to make sure that they think it's safe. And beyond that, in the absence of evidence, it's likely going to be, it'll likely boil down to how much time, energy, and money do you have for that. I think that people do seem to be more likely to feel that they get something out of something that they're intrinsically interested in.
Sure.
And I think that there's more literature developing that is going to ultimately support that. If this is a thing that feels good to you, that you're very actively engaged in, then I think that that's different than having somebody, massage your back for an hour while you just lie there and expect to get some type of benefit from that. The more actively engaged people are in the intervention, the more they seem to get out of it.
Great. How important is family and support during this process?
Certainly weigh in, guys, if you think that you have more to add, but I think it's critically important. This is typically a period of time where people are maximally stressed. This is, it is by its nature something that people don't anticipate and are unable to anticipate, and as a consequence, the more support people can get from family, friends, community, the better, and I don't think that can be overstated.
Couldn't agree more.
Yeah, 100% agree. And there are lots of support groups that are out there as well. We have some through the university that really provide a lot of that support as well in case patients either don't have as immediate family around or things like that. That's something that we truly believe in. So I think it's critically important. I certainly agree.
You nicely anticipated our next question. How do stroke patients recover quality of life during this process? Are there programs out there to get them back to doing the things they love to do, such as UMAs?
Yeah, I think I apologize for monopolizing the time, but the UMAs program stands for the University of Michigan Adaptive and Inclusive Sports Experience. This is a program run by our therapeutic recreation specialists, and their job, their training, is in helping people get back to activities that they enjoy. So this is part of those folks work in our inpatient rehabilitation unit and start working with people as soon as they start our rehab program, with the idea being that if somebody's got a specific leisure activity that brings them a lot of joy, improves their quality of life, that we're helping them start think about how do I get back to doing those things that I enjoy right away.
Sure.
So the UMAs program translates that whole project of improving somebody's community integration and their ability to get back to what they want to do into the outpatient world. So they might do adapted kayaking, sailing, other sports, cycling, those kind of things. So people can look up the UMAs program Maze with an SE, and determine if that's something that they're interested in.
Great, thank you. Switching gears back to another viewer question, does sleep apnea cause mini strokes?
So that's a tough one. So we know that, especially in men, sleep apnea increases the risk of ischemic stroke, and there's certainly a relationship between the two, which is being further investigated by actually a number of clinical trials. So we know that sleep apnea and stroke are associated. Whether sleep apnea is specifically associated with mini strokes or TIAs, I don't know the answer to that, and I don't think that's actually known. But this is a very good point that the two are related, and we're looking for evidence that treating sleep apnea hopefully reduces the risk of stroke. At this time, that's not known.
Thank you for that.
I also, if you don't
Go
mind,
ahead.
just want to throw out that if people are known to have sleep apnea and have had a stroke, that's certainly a good reason to get your sleep evaluated further, since there's some evidence that not addressing your sleep apnea or not having a CPAP machine or something like that can actually impede your progress after your stroke.
Yeah.
Along those lines, I guess we haven't really got into it too much, but when we look at all strokes that happen in the United States, ischemic strokes per se, about a quarter of them are from a recurrent stroke, somebody that's already had one stroke and then has another stroke. So another phase of stroke care following the actual incident or initial stroke is going to be making sure that you're following through with a stroke clinic and optimizing your ability to not have another stroke, or improving medications, things like that, to prevent that second stroke from coming down the pipeline.
Thank you for that. Looking forwards, looking towards the future, what does the future look like for stroke patients? Are there new treatments or technology on the horizon?
In terms of acute stroke, the biggest change that we expect to see over the next 5 years is that the treatment window is getting a bit larger. So whereas before, say, 2010, I think, we could only treat patients within 3 hours of stroke symptom onset or symptom discovery, we now have some treatments available out to 24 hours. And this is a huge shift in acute stroke care. And I expect that window will continue to expand for various treatments, which will allow us to treat more patients, and is really a wonderful thing.
Yeah, I couldn't agree more. I think stroke is clearly in some cases a devastating illness, and as physicians, it's really exciting for us because the landscape is really changing. We are expanding those time windows, so we're being able to provide more treatments to more patients than we ever have been able to before. So it's a truly exciting time for us.
Yeah, I think further on the rehabilitation side of things, after the acute interventions have been done, there's a lot of ongoing exploration of various medication options that can maybe facilitate further recovery. There's ongoing work in robotics and exoskeletal designs, as well as stem cell interventions.
And even with stroke prevention, there are new medications, new blood thinners, new even devices that can help prevent stroke for certain diseases, like from carotid disease or heart disease. So those are kind of on the forefront, and we expect to see more of those in the next 10 years.
Great. So as we close in on the end of our Facebook Live, what parting thoughts would you like to leave our viewers with about stroke?
So I think we kind of hit that at the beginning, but I'll try to make sure that I kind of recap that. So getting treated quickly is paramount in stroke. So if you're having symptoms that are acute in onset, please don't wait at home. Please don't see if it's going to improve. Please don't, say, gosh, I'll take a nap, but when I wake up, if it's still there, I'll come in. Your immediate thought should be to call 911, or if you see a family member or a loved one or a friend, somebody that appears to be exhibiting those signs of stroke that we kind of remember FAST, F-A-S-T, make sure you call 911. Get them to the hospital immediately. That's the best chance you have available to get those patients the treatment that they need.
Fantastic.
Yeah. And I'm just going to, again, repeat the symptoms to be on the lookout for. So sudden onset, weakness or numbness, especially on one side of the body, trouble talking, trouble seeing, trouble walking, trouble swallowing, anything that comes on acutely like that, call 911.
I think beyond acute care, for the folks undergoing rehabilitation, I think the biggest thing is just that people need to continue to be comfortable asking their providers about problems that they're still having. People are at high risk for depression, anxiety, musculoskeletal or joint pain problems, problems with their sleep, sexual dysfunction, and people just need to be comfortable bringing that to a doctor because we're certainly comfortable hearing about it and trying to help.
Thank you so much. Thank you to our experts for your time, for your expertise. Thank you to our viewers for their questions. If you'd like to share this, it's on the Facebook page, and it will be on the Facebook page. We'll also be putting it up on the Michigan Medicine YouTube channel as well. So thank you to our experts and our viewers, and have a wonderful afternoon.
Thanks, Ed.